So for first up, we are very thankful to have Prof. Nyam and Ms. Lee Chen Yi to share with us more about the industry track challenge statement 1, which is on operating theatre resource and patient monitoring. So the questions which you are hoping to answer today is how might we have real-time oversight and overview of resources in terms of manpower, infrastructure, equipment, operating rooms, and patient movement across the perioperative setting. So I think we'll just start with Prof. Nyam to share with us TE resource optimization. Thank you very much.
Thank you very much, Christina. This problem statement is a joint statement between SingHealth and NUHS, and I'm very honored to have Chen Yi to co-present this with us. So I'm going to ask Chen Yi to start, and then I'll come in the middle with the other parts related to surgery.
Thanks, Nyam. So Chen Yi here. I think we'll start off by sharing a little bit about the current elective surgery journey. And by elective, we really mean planned. Elective doesn't mean optional. And I won't go into all the details, but suffice to say that when a patient first goes for an outpatient appointment at some point, when it is deemed suitable and there's mutual consent, there is an agreement, and the patient gets listed for surgery, receives patient education materials on the surgery procedure, gets a surgery date confirmed, gets various notifications on appointments that will be lined up leading up to the surgery. So these could include a pre-surgery counseling appointment, these could include blood tests, etc. And then along the way, prior to the surgery, there are notifications from the hospital system, whether NUHS or SingHealth. There could be phone calls from a pre-op coordination, so pre-operative coordination center, to make sure that the patient has complied to instructions prior to the surgery. These are all important instructions to make sure that they are prepared for the surgery. And then there are confirmations from calls from nurses, for instance, to make sure that they know what time to report, and have all the instructions well understood. When they come to the hospital for the surgery, we also, that's where they in some cases they come on the same day of admission. In some other cases they may be admitted a day before. In the case of in the case of SingHealth, there are also various modalities. I think over here it's listed using a nursing software suite, which is an iPad, to access patient education materials and test results. I think other similar modalities in NUHS as well. And then post-surgery, the patient then goes for care counseling, and then subsequently discharged. And there are other things that happen depending on the type of surgery. But of course, wound care is important, so that there will be different things that are done to make sure that the patient is well after surgery and is reviewed by the doctor post-surgery as well. So that's just a very broad overview of what happens for a patient coming for planned surgery, as opposed to an emergency surgery. Next, please. So what we are trying to share about in terms of our problem statement is some of the challenges that are faced not just for NUHS and SingHealth, but across many different healthcare systems, and not just in Singapore, but worldwide also. I think we see last-minute surgical cancellations, not because of any nefarious reasons, but because patients understandably will inevitably fall ill to a certain percentage on the day of surgery, or there could be certain cases which result in no-shows, whether it's because the patient forgot or something last-minute very important cropped up, etc., or because they didn't fully understand or didn't fully adhere to pre-op instructions. So these last-minute surgical cancellations then mean that the slot is not utilized, and that operating theatre and the entire team and the attendant equipment, etc., is not utilized for that slot. However, of course, there are many different ways, which I'll talk about later, where we then try to slot in other surgeries so that we make use of these very expensive resources. Other challenges are delays in the start time of operations due to various lapses, whether it's in pre-op preparation, timeliness of patient transport, patients turning up late, and so on. And then, of course, the fact that important patient information resides in different IT systems, so that takes time as well as planned operations taking longer or shorter than expected. Again, this is in the nature of healthcare. It's in the nature of surgical care because there will be unexpected surprises along the way, or in certain cases, certain things proceed faster than expected, which is a good thing. And all these various issues do result in suboptimized operating theatre utilization. Next, please. We also see downstream bed management issues causing delays in the timeliness of, well, delays in actually resulting in non-optimal OT utilization. So this is where we need to have a suitable bed for the patient to go to after the surgery. So whether it's a recovery bed or a surgical post-ICU bed and so on. So the correct and appropriate category of bed or high dependency bed, etc. Something that's appropriate to the patient. So there may be some issues downstream because again, there are inevitable and unanticipated issues that do crop up. And of course, sometimes things are not optimized because of these various things, various issues that crop up. So the post-anesthesia care unit also requires high manual monitoring requirements. So that's the nurses taking vital signs manually. So it's very labor intensive. Tracking of essential OT equipment and availability of surgery, that's also another challenge. Next, please. So various things are being done, and I would say if you compare NUHS and SingHealth to many of the healthcare systems in the world, actually we are fairly well optimized. But as I said, this is a worldwide problem, and various things will be done by staff to make sure that patients are ready for surgery, whether it's manual checks, manual calls by staff to make sure patients are ready, or whether it's an operations team to manually shift surgeries and slot in surgery requests on the various operating theatre systems on a daily basis. Just so that if one slot is freed up, we can try and slot something in, or if there's a change, you can just shift it around, and it's really all about trying to maximize all these that very limited finite resource. And as I mentioned just now, there is a somewhat manual monitoring of patients and tracking of equipment by nursing staff. Next, please. So having said that, I would also qualify to say that all these are very much broad brushes, right, of the problem. We haven't gone down into the details, but very broadly, I think this is something that matters because operating theatres are a very expensive resource in a hospital system, probably the most expensive in terms of concentration of resources for highly skilled manpower, nursing, surgical, anesthesiological manpower, as well as infrastructure and equipment. So every minute counts, and that matters from a cost and value perspective. But more importantly, I think for all of us in public sector, it is important that we optimize a finite resource because that will give improved access to care for our patients. They get to have a surgery earlier, they have less delays, and it's also better staff satisfaction for all our operating theatre staff, whether it's the surgeons or nurses and so on. And I think that's critical for well-functioning healthcare system. So I'm going to hand over now to Niam to talk a little bit more about what we hope to see in this collaboration. Thanks.
Thank you very much, Chenny. Next slide, please. So what we really want to address here is to provide a command and control kind of and communications view of all this the various steps in which the patient goes through the elective operating theatre journey. And this is looking for real-time overview, oversight, and through the use of visualization tools, tracking tools, as well as a way to alert clinicians as well as patients if there are any bumps that may be up ahead. We would also like to have predictive capabilities built into the software features so that we can anticipate problems that might crop up even before they occur. So some of the items that we would like this level of visualization and automation includes the pre-op checklist. As Chenny mentioned earlier, there are a number of patients who, on the day of surgery, develop some kind of illness. For example, they have a flu on the morning of the surgery, and they are unable to come for surgery. And this would have normally been a manual process where the nurses are alerted, then everyone down the line has to scramble to change the way we organize the operating theaters so as to optimize its use. We are hoping at this point where, as part of the pre-op checklist, the patients are allowed to, for example, call in or even send an SMS or message us to tell us that, okay, I'm really not feeling too well. And we actually can have a way of actively pushing up cases that are ready for the later part of the day to come forward a bit earlier. And this would really improve our efficiency and reduce the kind of wastage and disruption that we might have. The other part to this is that the scheduled surgeries, we want to have some active scheduled surgeries to be optimized in a way on the fly. So we want to have real-time way of optimizing the operative slots, because as was mentioned earlier, some operations end earlier and some operations end late. So I think that we must ensure that the OT scheduling is done in such a way that that it doesn't cause any issue to the optimization of the entire OT slot. And finally, of course, we would like to be able to say that using this C3 system, we want to be able to tell patients and their relatives, for example, where the patient is along the journey. And of course, in terms of the equipment location and status is important as well, because certain operations require a certain set of equipment. Today, this is done in a very manual fashion where nurses have to go and fetch the necessary equipment. So the next slide, please. So what we envision to have here is a central command, control, and communication system that allows us to onboard and link data, whether it is from OT management systems. In NUHS, we use something called OOTS, which is the equivalent. Bed management systems, which we mentioned earlier, that has an impact on how you can schedule the surgeries, and therefore the efficiency in which we use the operating theaters. We also like to link it up to predictive algorithms that can help us optimize the scheduling of the OT, as well as predict any potential hiccups that might come due to, for example, longer extended operations, as well as patient no-shows. And of course, this should be linked to a messaging system where it can interface with staff as well as patients via secure devices with appropriate assigned privileges. Next slide, please. So as a suggested technical solution for this C3 system, here are some high-level features for potential vendors to consider. So we would like to have integrated event-based messaging systems. So just some very high-level suggestions here would be the ability to integrate data and put out the data as message streams, so that microservices can consume those message streams, which implies that you want some form of microservice architecture to be able to onboard some of these functions, such as displaying and visualizing real-time information, being able to do alerts, trigger alerts to be sent to both staff and patients. One other feature is that we would like to see scalable live views. In other words, this is not a C3 system built for a small number of people. With the appropriate permissions, we would like most staff, especially people who are administratively managing the operating theatre, as well as on the ground staff who are actually encountering the patient interaction, as well as any problems they might face on the ground, to be able to see these views. So this is not like a single command center, but more like a customizable view for different people requiring different kinds of information. As mentioned earlier, well, we want to see some form of predictive ability using live AI scheduling and resource solutions. So this is the ability to predict and optimize the OT slots given the changing nature of whether operations go longer or whether patients don't turn up for their operations. And lastly, we want to see some form of automated monitoring and alert for patients and staff. This is related to the downstream event of post-operative care. Currently, we expend a large amount of manpower to just monitor post-operative patients, as that's a very high risk period just after the operation. So if we could have some automated monitoring and alert system, that would greatly reduce the manpower required and improve the efficiency of our operating theatre. Next slide, please. So the key outcomes that we are looking for in this particular problem statement is improved operational visibility using this C3 system to enable better decision support and decision-making capabilities. We desire that in this operational visibility, some form of automation and alerts as well. And ultimately, we want to improve the OT utilization rate. As Jenny mentioned earlier, this is a highly valuable resource and it will be a waste to run it suboptimally. And of course, our patients will get a better experience when they come for elective surgery at our hospitals. With that, I come to the end of my presentation. Thank you.
Thank you, Prof. Nyam and Chen Yi. So we'll move to the holding slide, where this is where we will now kick off the Q&A segment. So I've seen that a lot of us have been submitting our Q&A through the Q&A functions, and Prof. Nyam has also been answering some of the questions. So broadly, I think this was mentioned a little earlier about the KPIs. So there was a question about KPIs and whether we are paying specific attention to overdue patients, and also just wondering whether there would be additional data that will be provided in terms of, say, what's the time limit allowed for patients to be operated within, and whether there's like a historical data that can be shared throughout the challenge.
Thank you for that question, Christina. Let me take that question. I'm a surgeon, so I'm familiar with this problem. So we do have multi-years of data to look at historic operations as well, tagged to specific surgeons and specific procedures. The problem here is not exactly so straightforward, right? It's not an issue of saying that, okay, knee operations only take 1.5 hours and is immutable. In fact, this is a wicked problem because knee surgeries can span anywhere from 1 hour to 3 hours, right? And it's not so deterministic as to say that each surgeon will always operate within a certain parameter. And certainly you can't tell the surgeon to get out of the operating theater if they run out of time, right? So they need to complete the operation. So what is really required here is ideally some form of machine learning methodology to be able to take into account historic data, but also to be able to arrange scheduling of operations on the fly. Now, today, this is done entirely manually by usually the operating theater manager. It is fairly optimized, I must say, because nothing beats a human's intuition to be able to do this. However, the downstream processes are highly manual, meaning that if the operating slot shifts are made, everything is by a phone call, right? So if we could predict some of these things, anticipate them and be able to automate some of the responses with a human in the loop, I think that's the solution we're looking for.
Thank you. Thank you. And understanding the capabilities that you need, we have a question. Does this solution need to provide all the capabilities at the same time? So visualization tools, predictive capabilities, and automation. So I think the question is, does it have a single solution that does everything?
Yeah, maybe I'll take that. I think we're looking very much at the C3 for now. And then the predictive piece we can layer on. I would say, this is a high level mention because there is quite a bit of work that is proceeding in parallel tracks with other scientific collaborators at the same time for some of these predictive algorithms. So in different parts. So for this particular industry track challenge, we're really looking at the C3.
Okay, thank you. So there were also some suggestions on ideas and they wanted to consult with you. Or will staff be agreeable to wearing tags on wearables to track real-time location and action during their shift?
Yeah, all patients who come to OT have some kind of tags already.
I understand. And what about staff? Because I think there was this element of resource management and manpower, so staff is also included.
Well, currently we check our staffs with something called a mobile phone, so.
Okay.
Yeah. So we haven't put tags on them yet. So I'm not sure if it's entirely necessary, but certainly equipment can be quite hard to locate because equipment don't answer to phone calls, right? So an integrated solution to track the equipment would be useful.
Maybe I also respond to I think some of the questions that are asked, right, about whether all the OTs are the same. So they're not. There are many different. There are different types of OTs, hybrid OTs, major operating OTs, the day surgery OTs, and so on. And I think even for the surgical duration, besides the surgeon, whether it's the surgeon himself, the seniority of the surgeon, experience, type of surgery, the patient, the complexity of the surgery, some of the risk factors of the patient, these all play a factor as well. And then of course, it's not so easy to just transfer from one OT to another because there are issues about cross-contamination, for instance. Certain types of surgeries can only be done in certain OTs, and also some of it is equipment specific. So some equipment are so huge and specific and locked down that you can't move it easily, for instance. And then of course, nursing manpower is also something that has to be I guess taken into account. So there are various specializations of the operating theatre nurses too.
Thank you. Another question, because there's a lot of data component into the solution. So we have a few questions now, just merge them into one, about whether historical data and digital format could be shared, and would this only be shared now or after the proposal is selected?
Yeah, let me take that question. For the purposes of building neural networks and for training, after the proposal, yes, that's the idea that this kind of information would be shared to be able to train appropriate models.
Okay. I think there was a question by Natari on how do you see this solution complement the upcoming NGMR? So there are certain functions within EPIC that really tries to optimize the OT utilization based on trending of certain procedures. So Uptime, I think under EPIC was supposed to be able to provide insights into things like recommended duration of procedure. So is this solution essentially supposed to do it better than existing solutions?
Yeah, thank you for the question. I can take that question because the NUHS cluster is undergoing the transition to the NGMR, and indeed EPIC has a module called Uptime. So the Uptime actually replaces our current OT management module, which already features many of the functions that we've just discussed earlier. But here what we're looking for is a whole of OT tracking. In other words, we want to be able to track patients, equipment, operating theater resources, not just operating theaters. Okay, so I think it goes beyond just operating theater and operating time. That is something that is a current capability. And to layer on top of that, potential predictive capabilities in terms of the whole processes, including patients, equipment, and staff.
Okay, thank you. And if we look deeper into the specifics, we have a question from Margin. Is variability in procedure length a major concern, particularly unexpected longer duration due to complications during surgery?
Yeah, perhaps can take that question. Yes, so that is a concern because what currently happens is that if there is a unexpected extension to the surgery, then the operating theater staff would manually be rearranging the slots amongst throughout the other operating theaters to accommodate the following cases. Very occasionally, we may need to cancel some last cases because we just cannot complete those cases on time. So, this is a problem now, and ideally there will be some form of automation in terms of optimization of OTUs if such cases arise.
Okay. And I understand from Chenny, you mentioned that in terms of the predictive element, it's something that you look at later. So, but there are still some questions on it regarding whether there are any expectations on model accuracy for that.
Obviously, the more accurate, the better. But I don't think you reach a very high level right at the start, and the point is being able to plug in lots of data and improve it over time. So we are really looking for I think partners who are able to bring something to the table and who will be able to work with us on the different aspects. But as I said, certainly the predictive element as well as the effector they are all very important. But we want to look at the very initial C3 aspect first.
Understand.
And the others as layer ons.
And since this software solution is very dependent on current data sets to enhance it better, so there was a question from Ken. How are the data sets currently maintained and stored besides the manual elements? So anything there is a little more digital, how are they currently maintained and stored?
I think I can speak to that for the NUHS side. So currently the data is stored in one of our operating management, theater management systems, the OOTS system, which addresses most of the points that some of the questions have brought up. Basically things like availability of surgeons, availability of ward beds and ICU beds, the number of sessions that are permitted given a specific time constraint. And this currently is the current state of the software. So what we hope to have, as Chenny mentioned, is a enhanced version, initially being able to visualize all of this in real time, as well as to be able to later layer on predictive and effector mechanisms.
Hi, Christina. This is Franklin from SingHealth. Just to add on, for SingHealth, really, as what was mentioned also, our data, and I think this also addresses another question that I saw in terms of where the data resides from different systems, and it's precisely that. I think what we want is a system that can pull also data from different areas. For example, our beds, data on our beds resides in one system. There are also data regarding rostering of staff in different systems. So I think we are agnostic. We want something that can pull from different sources, and like what Prof also mentioned, moving on, we could have data source from even other areas that should be able to quite seamlessly be then integrated into this particular platform to improve the accuracy of some of this prediction required.
Thank you, everyone. So I think we have about 3 more questions. So please keep the questions coming. We have 262 participants here, and we're very, very happy for the response and enthusiasm. So some other questions that we are also receiving is in terms of the scope of what patient monitoring is looking at. So Anthony had a question: does the patient monitoring need to extend to post-surgical care?
When I just have a question there, when you say post-surgical care, here we refer to only one place, which is the post-anesthesia care unit, right? So this is immediately after surgery where we monitor the patients. Now, I want to be clear here that this is not a IoT question, right? We do have already monitors to monitor this patient. It's just about integrating the data into a C3 system. Yeah.
Okay. And with this integration and overlaying it, do you expect it to take into account current best practices and clinical pathways and overlay it with scheduling and predictions?
Absolutely. I think in terms of best practices, I think it's pretty standard across most hospitals. The duration of follow-up, duration of monitoring after the surgery, as well as the appropriate best practices. What we are really trying to say here is that in terms of monitoring, we really want to be able to have some visualization and hopefully some form of automation.
So we have a few questions coming in on constraints, and I'll talk about that a little later. So now we are at that looking at visualizing what kind of solution you're looking at. So one question we had from Sean is, have you considered VR and AR integration within the OT, and how might they be used to meet the KPIs of optimization, as you mentioned?
Yeah, I think they have been considered in various other contexts, but not specifically for flow optimization. We are using it in other contexts for the actual, for instance, planning of the surgery, and education, for instance. A bit less on the actual operations aspect. I don't know whether Niam wants to talk about that.
Yeah, absolutely. So we have already have ongoing initiatives to use mixed reality in surgery, but this particular problem statement really speaks to operation, OT utilization and optimization rather than the conduct of the surgery itself.
Got it. So I think there was a question on the list of constraints, and I remember this was mentioned previously in the slide, I think a few slides up to slide 16 on the list of constraints. But I think perhaps we could elaborate a little more. There is a question asking, what are the list of constraints to reach to the optimal situation? So I think what we're also looking for is, are there any behavioral elements or process elements that are constraining to reach to this potential optimal situation?
Maybe I can take that question first, right? So there are two parts to this. So there's a behavior and process, and I think the question correctly points out one of the key issues with OT optimization. That is, there's certainly a large component in which staff have to adapt to workflows to ensure that the OT utilization is optimized. So a specific example would be OT turnaround, for example. So staff need to be able to turn around the OT quickly to ensure that we can more effectively use the OT time that is available. So that speaks to things like staff rostering and ensuring that staff have sufficient amount of break to operate at that cadence. The second point about workflows really then comes down to individual specialties having specific workflows. And to that point, I would imagine that this needs to be optimized and ideally learned by the system to be able to ensure those workflows work in a streamlined manner. Jenny, you have any comments on that?
No, I agree with you. Nothing further to add.
Yeah, and this is Franklin, just to a quick addition, certainly, this C3 is not going to solve everything, but I think we believe with this C3 system, it then helps and augments some of the processes and workflows within the OT and beyond, so that, like, as we said, we can then reach the optimal level.
Thank you. So we have about a few more minutes, and we'll take in the last question. Any other questions, I apologize. We will not be able to cover today, but what we can do is to please feel free to submit that question you have, and then we'll compile it and float it to the respective team. So the last question we have is from Patrick. Which institution is in charge of training and planning for crisis management?
I think all the institutions are involved in that. But I just want to, so I mean, that's the short answer to that. But I just want to focus our time really more on the challenge statement, because I know, everyone has spent that time and effort to come in for this session. And there are going to be various submissions. So we just want to make sure that we are very clear on what we are asking for. We are not asking, as Nyam said just now, we're not asking for so much of a IoT solution for the post-surgical monitoring, for instance. We are looking more at the C3 system. And also, just to clarify, we're not looking at emergency surgeries, because that was also another question. We are looking at the planned surgeries. We think that that's a easier problem to solve in the first instance, and also has a more similar workflow across the different hospitals as well, and probably more predictable. And I think we also, another clarification is that we are not looking at the predictive algos as the very first and for front and center solution we are looking at. I mean, that's an important thing, but the most important part is the C3 piece.
And just to also clarify, I saw a question to ask whether this is going to replace our OT module within our individual system, enterprise system. Certainly not. This is supposed to augment and complement it. So we are not going to ask for a replacement of the Epic or the Sunrise system that each of our cluster are using.
Understand. Thank you so much, Prof. Nyam, Ms. Chen Yi, and Franklin, for your time in sharing and answering all these questions. I think from the response, we have a lot of interest, and we look forward to a very engaging and exciting submissions coming in. So thank you. I invite you to take a leave now.
Thanks very much.
Thank you.
Thank you.
Thank you.